Welcome to the Neuromodulation Podcast, presented to you by the International Neuromodulation Society. Dive into the forefront of today's emerging neuromodulation techniques, insights, and ethical and clinical applications. Subscribe now to join the multidisciplinary collaboration of medical care providers, scientists, and engineers who are part of the global conversation that's shaping the future of healthcare. Welcome to the Neuromodulation Podcast. I'm today's host, Mandi Soleil, and in this final episode of Season 2, I'm joined by Dr. Erika Petersen, Professor of Neurosurgery at the University of Arkansas for Medical Sciences, where she serves as Director of the Section of Functional and Restorative Neurosurgery and Program Director for the Neurosurgery Residency. Dr. Petersen is a board-certified neurosurgeon whose clinical practice focuses on neuromodulation, including the treatment of movement disorders, spasticity, and chronic pain through advanced surgical approaches and stereotactic techniques. Her research focuses on expanding the frontiers of neuromodulation, from developing new devices and indications for chronic pain to strengthening collaboration across neurosurgery, neurology, pain medicine, neuroradiology, and psychiatry. She's also engaged in exploring emerging considerations in the field, including device cybersecurity, equity in surgical practice, and the use of virtual reality in clinical care and training. In this conversation, we explore Dr. Petersen's clinical and research journey, the evolving role of neuromodulation in pain management, and where the field is heading next. Thanks for joining. Welcome to the show.
Oh, thank you.
Sounds good. All right. So diabetic and peripheral neuropathic pain affect millions of people worldwide, and treatment options, despite that, remain pretty limited. What would you say makes these conditions particularly difficult to manage?
One of the big problems has been is that the medications that people take as first line for painful diabetic neuropathy have a lot of side effects. So it's been studied, and a lot of people take a gabapentinoid like either Neurontin or Lyrica, and up to 77% of people will stop taking Lyrica within the first year that they're prescribed it because of side effects, issues with tolerating it, it doesn't work as well, or it's just too expensive for them to afford. And so when you are limited numbers of medications that make an impact, and then you have those sorts of things, grogginess, drowsiness, balance problems that come on, people don't want to take the medicines. And so it's been really important to try to expand opportunities of how you can treat this real big problem for a lot of patients with something different.
And actually, I'd love to get a little bit of an understanding. Can you share the scope of your practice right now?
So I'm a neurosurgeon in an academic practice. I'm a professor at the University of Arkansas for Medical Sciences, and I've been there for nearly 15 years. And so as a functional neurosurgeon, I do general neurosurgery, I take call, I do trauma, I do spine surgery and some cranial work, but about 90% of my practice is actually neuromodulation. So I do deep brain stimulation, spinal cord stimulation, peripheral stimulation, intrathecal pump therapy, all of those things. And when I got to Arkansas, there wasn't anybody doing a specialty practice in functional neurosurgery. So I've really built that since I arrived.
And how did you fall into the neuromodulation space? And I shouldn't say fall, but it seems to be the case for many.
Yeah, well, I mean, I think that, a lot of neurosurgeons start off in their residency training sort of dazzled by the complexities and excitement of aneurysm surgery or tumor surgery. And I certainly found those attractive as well. But when I saw my first deep brain stimulator case for essential tremor, and to see how somebody could go from having a tremor where they couldn't write their name to instantaneously having control enough to make a legible signature, it really is an impact. And it's one of those amazing ways that you have an immediate gratifying difference in somebody's quality of life. And so that opportunity, and plus what we can get in terms of pain relief outcomes using spinal cord stimulation, was really attractive to me. The other part of neuromodulation is just the opportunities for innovation. There's so much that is being understood and developed from what we know from mechanisms and how we better understand how the nervous system, how it can interact with what we may be able to do with technology, but then also what those technologies can look like in terms of miniaturization and new innovations that come along. So it's a very exciting place to be.
And then you've done a number of talks. We're at the NANS convention right now in Orlando, and you have a number of talks on diabetic neuropathy. Curious, is this a particular focus for you or just a research topic of interest at the present moment?
I tell people when I talk about it, that I never would have expected as a neurosurgeon to focus on diabetes. But it's one of those things where when you're pursuing opportunities, you have a lot of conversations and look for a lot of potential places where we may make an impact. And obviously, spinal cord stimulation has biggest and most in-depth and longest term evidence in chronic back pain and leg pain. And the idea of expanding that to new populations and expanding what we can do for other kinds of pain conditions was really attractive. And so I happened to be fortunate enough to talk to some people who were starting to look at diabetic neuropathy based on some early work that was done and suggesting, well, maybe we can use new waveforms that don't create paresthesia when people already have painful burning and tingling and itching feet. Maybe we can use these new feelings of stimulation where you don't feel the waveform to have an even better impact in terms of patients' pain and quality of life. And so I've been very fortunate that research has continued to pan out, and we've been able to show some amazing results from that and really follow a whole new track. You know, in the US, there's 37 million people with diabetes and 88 million people are pre-diabetic. And so if you think about the numbers of people who have painful diabetic neuropathy, it might be a quarter of that. So, maybe 5 million or so. It's a large number of patients that we may be able to unlock this opportunity to get some relief from.
So historically, spinal cord stimulation has been focused on treatment for chronic pain. Can you speak about how this has evolved in addressing diabetic neuropathy over time?
Yeah, so diabetic neuropathy is still a chronic nerve damage related pain. It happens with small nerve fibers over time related to the disease process of diabetes. One of those things that you expect is that people who continue to have diabetes and are developing neuropathy will have worsening of that neuropathy over time because they are chronically exposed to having diabetes and poor glucose control. And so, the majority of evidence in spinal cord stimulation has been published looking at nerve damage related pain, neuropathic pain. And so it makes very good sense that an area like this, where the nerve damage is coming from diabetes or potentially from other indications that aren't post-surgical but still fit into the neuropathic component, for example, chemotherapy-induced neuropathy, may be areas where this could potentially help.
And you spoke a bit about the evolution of how medication management works for diabetic neuropathy. When you're evaluating a patient for neuromodulation, what's that looking like from moving from medication to neuromodulation? Is medication always a starting point? Do you ever start with neuromodulation?
Yeah, so based on the research that we published, the 6-month results of our study looking at 10 kilohertz spinal cord stimulation were published in JAMA Neurology in April 2021. And I've wanted to emulate the guidelines in terms of the inclusion and exclusion criteria of that study and how I select patients in my own practice. The American Diabetes Association has published guidelines for how to treat diabetic neuropathy, which say to trial one medication first. If that doesn't work, trial a different class of medication or possibly 2 classes together before you really know that somebody has refractory diabetic neuropathy. Patients may respond to medications, and one of the biggest risks of a medication is side effects or not being able to continue it for some reason. That's a lot lower risk than any sort of implanted procedure that I do as a surgeon, and so I certainly think it makes sense if something can be helped with medication, maybe I shouldn't go straight to surgery for it. I think that also helps patients know that this is a process of things. That said, though, about 44% of people who try medications aren't going to respond to anything. And so they really don't have a lot of options. And so that's where then introducing spinal cord stimulation makes sense. And so patients who've had, first of all, who have diabetes, so that you know it's diabetic neuropathy. 2, they've had neuropathic pain for more than a year, so it's chronic. 3, that their pain is severe, at least a 5 out of 10 on the visual analog scale in their feet, and that's the population that we studied in the research study, and that they've tried those medications and they're still not responding. And of course, that they're safe to have a spinal cord stimulator. They don't have any of the surgical risks that would contraindicate placing a stimulator for any other reason. Those are the patients that I start to talk to about a stimulator at that point.
And we will link to the JAMA article in the show notes. I'd like to ask if there were any findings in that research that you found particularly surprising.
Absolutely. We've published several follow-up studies after that original JAMA neurology study, including a couple just within the past few months that were done looking at secondary outpoints and other observations. The original design of that study took some of the design was informed by a pilot study looking at polyneuropathy. And in that study, there were observations that people reported that they had improvements in sensation. So one of the things that we wanted to look at in the design of the diabetic neuropathy studies with Senza-PDN was to see what else besides pain may be changed. Because in diabetes, sleep quality is affected, mood is affected. Patients, obviously, you worry about their weight and their A1C, what their glucose control is, and you worry about sensation. One of the largest complications with diabetes is diabetic foot ulcers that might lead to amputation and might lead to even morbidity or mortality. The risk still higher when somebody has foot problems and diabetes of morbidity and mortality than if they have healthy feet. And so it was really important for us to look at those components as well, sort of look holistically at the experience of a patient with painful diabetic neuropathy as opposed to just looking at it for pain relief alone. And it's one of the first studies that's been designed that way to look at all those elements. So I was hoping that we would find signals in this, but what really surprised me is that we saw very strong signals in that. So these are patients who continue to have diabetes. So you would think after 24 months in a research study that their foot sensation would be worse, right? The diabetes is still there. The thing that is causing neuropathy is still there. What we found is that, first of all, that 66% of people in the study had improvement in neurological function. The majority of those were sensory. And it was maintained for 24 months, and in some cases, a little bit better. So these are people who, again, I would have expected their sensation to be worse at 24 months, and they were better at 24 months. So that is huge because the paper that we published in November of 2024 talks about loss of protective sensation. There are 4 points on the sole of the foot, and if you have all 4 of those, you have low risk of having foot ulcer injury because you have low loss of protective sensation. But if you miss one of those 4 points, now you're at high risk of protective sensation loss, and therefore you're at much higher risk of those foot ulcers and possible amputation and other injuries. And so what we saw in that, when we looked specifically at those 4 points over time, is that people who received a stimulator, the numbers that went from the low risk group doubled after they had a stimulator. Wow. So we could move people from the one group to the other. That's really, again, a result that I've been thrilled about because we're talking about the overall health of these patients and not just about making their pain better.
And I'm wondering, can you share what polyneuropathy is for anybody who might not know?
Yeah, so while diabetic neuropathy is one of the most common causes of small fiber nerve damage and that sort of pain, when you have multiple nerves in multiple areas that have that nerve damage to them, I call it polyneuropathy. Okay. And that can come from a lot of different sources. For example, like I said, after chemotherapy, it could be from a vitamin deficiency, like vitamin B12. It could just be idiopathic. We don't actually know where it comes from, but we know that people have that nerve fiber damage. So in that pilot study, the group that showed the most promising signal in terms of response, not just in terms of their pain relief, because 6 out of 7 people with diabetes in a small set of 18 had an improvement in their pain, but also then we saw these sensory changes, and that's what led to the bigger design.
Okay.
Yeah.
Fascinating. And incredible results. Were there any findings that were disheartening or not what you expected in the converse?
You know, I've really been very grateful for the study. I think that, as a surgeon doing a study where we only placed percutaneous leads and we had a few cases that needed migration or something like that, I was like, well, if that had been a paddle, maybe it wouldn't have shifted. But overall, the complication risk, the adverse event risk within the study were very low. We showed great safety within the study as well. And our infection rate, I was expecting that people with diabetes might have a higher than normal infection rate. But when you compare that to other spinal cord stimulator trials with people who don't have diabetes, the rate of infection was comparable.
Wow.
So thankfully, things bore out very well. I think that the correlate to that is then you want to see that a clinical trial also can be replicated in the real world. And there's been some publications now looking at real world series of patients that aren't within the regimented research protocol who've been able to show similar pain responder rates as well as quality of life responder rates that match what we showed in the clinical trial as well.
Is there anything else you'd want to speak to with respect to this shift to sensory restoration?
Yeah, so I think this is a really important thing to note, where we've talked about this idea of improvement in pain scores. Can we get 50% of people to have at least 50% reduction in pain? And that was our bar for quite a while. Then we started seeing publications that said, well, we can get 80% of people to have 50% reduction in pain, or we can see people who are profound responders who have at least 80% reduction in pain. But we're still talking about reductions in pain. So I think that the conversation that's happened in the past couple of years to talk about holistic response has been really important, because we know with pain comes quality of life, anxiety, depression, and other factors, including the overall ability to function. And if we can look at all those scales and show that people have met some sort of clinically important difference between the baseline and where they are at the end of the study, we can actually quantify that we are helping people across multiple dimensions. And so when we look at that for the diabetes population, again, the metabolic changes, loss of weight, improvement in A1C. Then you see the loss of protective sensation that's improved for people, sensation in general, sleep quality that's better, functional quality of life that's better. We're using EQ-5D scores, and then overall patients reporting significant satisfaction and global impressions of change that are much greater, not just pain. That's the bigger story, because when we got into this to treat pain, what we wanted to do was make people better, not make their pain go away, but make them better. And so I've always thought about neuromodulation as a tool to enable a transformation for a patient. So if a person decides that a device is going to help them with that transformation, they can say, I'm going to get a stimulator. But then they also need to be able to change what in their life has been affecting them and how that pain has shaped the rest of their life situation. And so for me, I might say, well, I want to change my life by buying a piece of exercise equipment. But I also have to make a commitment to use that exercise equipment and change my lifestyle and behavior. Acquiring the exercise equipment is only the first step in that process. And so if we think about the holistic part of what we're affecting with a stimulator, I think that it provides a much more comprehensive way of actually talking about how we enable patients to become better and what our role is in that journey. But we also need to provide them the support to make that transition.
And how do you go about navigating that as a neurosurgeon? Mm-hmm. You only get so much time. Can you share not only that, but how you're approaching things from an interdisciplinary perspective?
The interdisciplinary part of it is huge. I work very closely with my colleagues who are interventional pain physicians. We are co-investigators on each other's research studies. We are collaborators. We're co-implanters for some patients where we get to work in the operating room together for cases as well. And so I think it's very important to have that communication. But the same goes for our psychology team. I feel that the neuropsychology evaluations that we do for patients are very important for helping to inventory what some of those life situational factors are and the recommendations for whether somebody needs to have concomitant therapy. We need to talk about rehabilitation or exercise. Beyond that, in the physical fitness side of things, those are all part of the conversation. And I emphasize that when you add neuromodulation to somebody's overall experience in managing chronic pain, what we're talking about is one more tool in the kit. But that doesn't mean that you take it and just go to a straight shot of tequila. You still mix things together. You got to have a good margarita in there somewhere, right? The recipe involves a lot of ingredients, not just one thing.
Can't forget the salt either.
Yes, very good salt.
Would you say that there are any particular factors that you've just observed as trends as far as influencing the most positive outcomes for your patients?
One of the things that I think is probably the most important is seeing somebody who is an active agent in their own care, who's proactive and wants to take charge. I often see patients who've had a list printed out of all the surgeries that have been done to them, and they tried this, and then the surgeon did this, and whatever. And it's very passive and receptive of the healthcare industry, as opposed to, I sought this out and then I tried. And a passive voice and active voice in that attitude, I think, is something that's really important in helping to understand what somebody's perspective is and what they may envision in terms of their outcomes and goals and what's feasible. And that's, again, where I think having a conversation with somebody to understand where they come from is important, because the context of what brought them there is individual to them. And how they're going to react to having a neuromodulation procedure and go forward from that is going to be very individual to them as well. What they're equipped for is really related to what their goals and expectations are as part of that too. So I try to listen to that so that we can try to shape and agree that this is what I think I can offer as a surgeon. But then what they do with that once they've taken that on is really going to be up to them as part of it as well. And so it's not an exact science. I wish there was some sort of biomarker or something, but I know that there's instances where we just get that gut instinct as clinicians that this is a person I'm worried about, or this person I feel very confident and comfortable with, or this one I need to see another time to make sure that they really have a good handle on what they're getting into. And I think that clinical judgment, that art of how we practice relating to our patients, is really an important part of that.
So one of the talks that you've got at NANS right now, and I've seen a bit about in the research, is around 10 kilohertz SCS. Can you share what that is as opposed to other types of SCS that might treat these populations?
Yeah, so 10 kilohertz spinal cord stimulation was FDA approved in the US in 2015. It is a high frequency, very high frequency stimulation waveform where most tonic or the conventional stimulation before that time sort of is in the 40 to 60, 100 hertz range. And so if to put it by comparison, we think about frequencies, our ultrasonic jewelry cleaners work at about 3,000 to 5,000 hertz. So this is 10K. So it's an ultra high frequency where the difference is with the conventional stimulation, patients feel a vibration, a tingling or a thumping or fizz kind of sensation, depending on what that frequency is. At 10K, there's no perception of a sensation at all. There's a difference of mechanism. Part of what's been interesting about this is to try to figure out the underlying part of why one thing works differently than another. And it makes sense, I guess. The human body responds to different frequencies in different ways. And so if a low frequency is delivered over the dorsal column and spinal cord, it seems to act within the dorsal column and then travels in different areas, whereas 10 kilohertz seems to travel directly into working in the dorsal horn area. And there's different discussion about whether the mechanism is inhibiting different cells, activating in different locations, depending on what sort of mechanistic research we're doing. And so that is still in process to try to delineate which one works in what way. But what we know is when you look at a lot of different waveforms, and other things have developed since the 10K to change the field to where there are other kinds of stimulation that people don't feel as well. And this again goes back to why I'm so interested in neuromodulation. I'm enamored with the innovation that we have in this. But when you look at options, I like the idea that we have a lot of different options that we can try then to partner to different patients in their situations. And when I see a patient in the office, we may have a conversation to say, this is your condition. These are different features of different stimulators that are available. Is there something that resonates to you one way or another? For example, I have some patients who may not feel comfortable recharging a device implanted in their body. They prefer a primary cell device that they don't need to maintain. I have a few patients with cognitive issues. I'm a busy surgeon. I don't like to charge anything, my phone. And if I can't imagine integrating charging that into my life without, having some difficulty to it. Other people like incorporating that, and it doesn't really affect their lifestyle to have a rechargeable device. The 10 kilohertz stimulator device, because of the paradigm it has, is a rechargeable device. And so I may not be able to offer that to somebody if it's not something that they can actually keep up with and maintain the technology. We may have to talk about another alternative. And so that's why it's nice to have flexibility and options within our space.
Comparably with low frequency devices, would you say that this sort of perceptual awareness of the device and of this vibration sensation is comforting to some people or helpful?
Yeah, so I've had some patients who absolutely love feeling like they have a little massage or reassurance that's there. And I've offered for them to try new innovative waveforms. Some of them who've had stimulators for quite a long time, they come back for IPG exchange when the original generator they have is run its life course, and the new one has new features unlocked on it. I said, well, do you want to try the new stuff? And they're like, I'll try it. But they like to switch back to what they like. It was familiar. They're comfortable with it. I liken it to one patient who told me it was like when they first figured out there was an electric car and they didn't hear the motor purring. And they're like, how do you know this car is running if I don't hear the motor purring, So there is some comforting to that. There are other people who don't like that sensation. They feel like, well, maybe it'd be great to get a little vibration massage 15 minutes, but can you imagine doing that for 3 years straight? Maybe they wish they had just quiet in their own body as opposed to feeling that vibration. And so again, Different people have different tastes. And that's where I had a patient who previously had worked for like the power company and had an electrocution experience while he was doing some work. And we tried a stimulator, but I didn't know that ahead of time, but he did not like feeling buzzy because it reminded him of that work incident.
Makes sense.
I'm like, well, gosh, I wish I'd done that before we picked a branch, you know? And so understanding, and that's where that conversation with patients, I think, matters so much, to understand what they're coming to that experience. That was clearly unique. There's no way I would have guessed that about this patient.
Right.
And so again, having options that we can tailor to one person's preferences over another, and having science to support efficacy for all of those options is really so important, because I want to pick for each patient, where do I have the best science to say this is going to have the highest likelihood to work for them? And where do I have the features that are going to make sure that they can actually interact with the device and continue to use it effectively? And if it's not working, they're not going to use it. If they can't make it work, they're not going to use it either. So it has to be the two together, the science and the manageability.
How much troubleshooting are you undergoing with patients then to discern which device to use? And as a busy neurosurgeon, how do you keep apprised of all of the advancements in the technology?
Yeah. I'm just curious about that stuff. I don't spend a lot of time on sports or fancy race cars. This is kind of the area that I sort of, I guess, developed my depth on, but and it's obviously, it benefits me for work to be on top of it, but and it helps a lot to be at a meeting like NANS and to hear from others what their experiences are with different things as well. That's just such an advantage to be able to compare notes with my colleagues on things. In terms of keeping patients apprised about it, I try to reduce it down to, are you able to charge or not charge? Is one of those more important to you? Let's talk about MRI access and how important having MRI may be to you, because those conditionality ratings are different from company to company. Let's talk about the science for that patient's particular diagnosis. Let's talk about whether a closed-loop automated opportunity might be something that is to consider as well. And then once we talk about those, then they may express some preferences, and then we may talk about things in more detail at that point. But I try to keep it sort of high level as far as how I educate people into what a pacemaker for pain is and how they're going to be able to try to use that.
And our listeners have a broad range of neuromodulation experience. So on the MRI side of things, can you share, say you have a device that's not MRI compatible? What does that look like if somebody does need an MRI?
Yeah. So, well, first of all, I counsel patients that we have very few people who've needed their heart pacemakers removed in order to get an MRI, if it's there. And there were doctors who did okay diagnosing things before MRI was invented as well, right? So we should be able to work around that to a point. But there are a few instances where we've needed to do surgery to remove a device or to upgrade it to an MRI conditional device that will allow a person to get an MRI. And you have to do the surgery to remove the device then, or to do the revision. And so, but if we can get the answers diagnostically with other testing and not need an MRI, then a patient can avoid that surgery. So I'm a big fan of minimizing surgical complications. One of the ways that I tell patients that I like to do that is not operating unless we know for sure we have to.
But you would say minimally a problem.
Yeah, I mean, there's, again, MRI access has become more and more important, and I support that. And obviously, you don't get exposed to X-rays when you are having an MRI scan. But, you also don't necessarily want to jump straight to surgery with something. And even the devices that have fairly good MRI conditionality, there may be up to 10% of those devices that may fail and go into a non-MRI conditional mode. There was a study from Mayo Clinic that showed that a couple of years ago for a couple of devices. And so it's important, I think, again, if I have a patient who has a known history of cancer or a high family risk history, that we might need MRI in the future, we may lean more into that as one of the importance in terms of how do we have the best chances of maintaining MRI access, as opposed to some of the other factors that I enumerated.
So there are also various perspectives in the field on peripheral nerve stimulation and spinal cord stimulation, particularly for peripheral neuropathy. It'd be easy to assume we go straight to peripheral nerve stimulation. That's not always the case. How are you discerning which path to go down?
Well, I personally am a neurosurgeon, and I prefer to stay in the central nervous system. So I don't do as much peripheral nerve stimulation, particularly in the extremities, as I do spinal cord stimulation. And I think that, again, it comes to strength of evidence. And so there are a few small studies that have been published looking at both dorsal root ganglion stimulation as well as some peripheral nerve stimulation to address diabetic neuropathy. But the strongest and most powerful RCT is the one that we did. And so until that strength of evidence is there, and we can show also not just a pain relief benefit, but show all those other elements, including sensory and loss of protective sensation, those components of improvement, I'm going to stick with where I feel most comfortable with my evidence. Now, if a person is not a good candidate for spinal cord stimulation and that's not an option to put leads in the canal, then a peripheral stimulator may be the only option to try to address a portion of their symptoms. And I'm still a fan of helping make the person better, and some better is better than not doing anything at all. And so that may be an instance where we would say, well, let's see what we can consider with a peripheral nerve stimulator. And typically that's when I collaborate with my interventional pain colleagues on things.
I'd love to be inside the mind of a neurosurgeon for a moment here. You said, I prefer to stay in the central nervous system. Why is that if we look at it more theoretically?
Oh, that's a good question. I mean, it's my happy space. There's spinal fluid and, it's just beautiful anatomy and it's what I do,
Yeah.
and frankly, it's what I'm trained to do. When you do peripheral nerve stimulation, a lot of that is identifying structures with ultrasound and other things that I'm just not as trained to do as my other colleagues do. And so because I work in an academic center where we are part of a group where we can complement each other's skill sets, then I've focused on my area, which is neurosurgery and the main OR, and then my interventional pain colleagues are able to pick up the other parts of that. And we really complement each other well on that.
I'd love to hear your perspectives on remote monitoring in SCS. I think that's pretty hot button topic.
Yeah. So this has been a really interesting opportunity. Like a lot of things in spinal cord stimulation, some of this has been pioneered out of the cardiac space, and then we see that we can also have it work in the neurospace. And so obviously remote cardiac monitoring has been around for quite a while and has helped to improve people's outcomes with congestive heart failure and other cardiac conditions, and allows for those cardiologists' offices to keep tabs on the health of their patients and to have proactive interventions when somebody may be close to a tipping point. That helps them to prevent a trip to the emergency room, helps them to prevent some sort of a decompensation episode. And so it makes really great sense to think, instead of waiting for a patient to call my office and say, this darn thing hadn't worked for 3 weeks, my pain is back and it's worse. And then we have to do the troubleshooting and work with the technicians and try to actually optimize and figure out what's going on. What if you have a system that's surveilling and is able to tell that the device is charging effectively, that the impedance levels are reading correctly in range, that everything that seems to be okay on the dashboard is in the right zone? And what if, because that's automated and checking in the distance, when there's an alert signal, it's kind of like getting a warning light on your dashboard. You know that there's something you should probably pay attention to, and we can proactively contact the patient. Hey, is everything going on okay with the device? It looks like your charging is having difficulty over the past few days. Is that something that we can help with? Oh, no, my power's been out because of the ice storm or something. You can very quickly get to that. And one of the benefits to this is that we talked about patients need to feel confident that the device is working in terms of pain relief and that they can work with their device. If the device they feel isn't working, the longer that it's not working, the more frustrated they become. More frustration turns into more dislike of the device and probably leads to higher explant rates and loss of efficacy rates, because you're reinforcing this negative nocebo effect of the device. If it's working well, or you can short circuit the time it would take to have it adjusted and get to working well again, then you maintain somebody in a place where they don't get into that cycle of frustration. And ultimately, then it doesn't inconvenience all those other holistic aspects of their life. Their quality of life isn't affected, their sleep isn't affected, all those other things that are not pain related. You may be able to actually preempt seeing those things become worse for them as well. So in the studies that have been done looking so far at remote monitoring, there's demonstrating an effect where the time to make adjustments is faster, patient outcomes are improved in using a device that has this remote monitoring attached to it. So I think there's a real great opportunity to provide that level of support proactively.
Do you have a prediction for the long game as far as whether or not that's something that becomes standard?
I'm optimistic about both remote programming and remote monitoring. I've had the opportunity with COVID, as we all did, to try to figure out how to take care of patients when you can't bring them into the office. And if you are able to get remote information or even to make changes to a device remotely, with that sort of telemedicine encounter as opposed to an in-person, you are going to help with improving overall patient satisfaction and quality over time, I think. And so it certainly makes sense. It's always great to see pioneers, and the fact that we have one company that sort of said remote programming is possible, and other companies seem to be interested in trying to see if that can be something that can be accomplished with their platforms as well. And the same for the remote monitoring side. I can't think of very many people who like to take a whole day off work to drive 6 hours round trip to my office just to have somebody say, oh, you didn't charge it enough, we're going to have to fix that later. And so if I can help somebody in their own community without that trip to get something optimized and get them that result, I keep them at a better level of quality of life, right? And so why wouldn't I want something that gets them that and then therefore improves their global impression of change and their overall patient satisfaction as part of things as well?
I'm even just thinking about accessibility over the long term. We're all aging, right? And our limitations, our access, our mobility, all that changes throughout the lifespan. So it seems like it's optimal in many ways. So you've done some interesting work around big data and AI with respect to neuromodulation. Can you share a little bit more about that?
Yeah, so this is a really interesting area as well, and something, again, where the question is, how do we take the insights that we can get from data and use that to inform how we optimize patients? And there's a couple of different ways to think about that. One is, can we use what we learn from large populations of patients to try to better select patients to have neuromodulation or to match a patient who we think is a candidate for neuromodulation to the right device? Can we do some data matching to really say, okay, this person has a high likelihood of success or a low likelihood of success, or maybe there's a gray zone where we're never really going to be able to parse it out until we try it. But I think there's some real value to learning those lessons. Then the other part of that is, what if we could use the patterns of how people interact with their device to shape how other people and recommend how other people use their device? So when I'm online shopping and I put things in my cart, it pops up and says, would you like to buy these other things people like you have also looked at? And so it makes a lot of sense if we know that somebody, for example, who has diabetic neuropathy has chosen this kind of setting for their device. Maybe, they answer a couple of questions interacting with an app. And then after they've answered those questions, it pops up and says, people like you also might like these 3 things. Would you like us to try that? And they could say, yeah, I'll try that one. And maybe they try out a different program for a while. And it's like somebody suggesting what I should listen to next after I've finished a song on my streaming service or something, because I like this, maybe I'll also like this one. And so as it's learning my habits, and the AI and the algorithm can sort of predict based on the habit of what I'm doing, that other people who are showing similar patterns of habit, that may also help to shape me. And if that gets my personal results as a patient trying this 3% better, even that little extra percent as part of that recipe of everything that they're doing to improve their pain overall, because we're talking about managing the chronic problem of pain chronically, then 3% matters. And so, yeah, I'll try that little bit. Didn't like it. I can go back to the one after that. I've hit skip on a lot of songs when they're suggested to me. I'm sure you have to too.
Too true.
Yeah.
Well, I can imagine that there's a level of attachment that can come. I have these settings. I know it works for me this well, but it sounds like using statistics effectively to guide more open-mindedness in the process might be an opportunity to trial and error a little bit with ourselves.
Well, part of that comes down to, again, if you're able to predict these things off of large data patterns, it's much different than one person just punching buttons and let me dial up this setting and see how that fits, or let me dial this other setting and see how that fits. It's that part of trial and error and is much more challenging and time consuming than if you were able to say, well, here's 5 different things that you can try through. Let's see what they're like and move through these options. We think that these may fit already based on some information that's there. So yeah, I think also that as we are getting more and more of that stuff suggested to us, like I said, with online shopping, for example, with our streaming services for consumption of music and TV and video, those sorts of things, more and more people know that an algorithm is presenting things to us, and the algorithm is learning about us and trying to help us in some way. And if they already have a trust in the device, then hopefully they have a trust in the algorithms that are built by the device company to try to help optimize that performance as part of it as well. And they'll be willing to give that a shot. But I absolutely agree that I would never want to erase my favorite program if I had a choice. I want to keep that one saved. I know you can mess around with these other ones, but I want to know I can go back to that standard, good old favorite if I needed to.
Protect the playlist.
Protect the playlist, exactly.
So I'm curious, with spinal cord stimulators, what level of immediacy are we looking at with trialing out different settings? So if I set my setting, do I know exactly what it's like for me, or does it evolve over time? And what does that timeline look like?
So there's some that are immediate effects, and there's some that are wash-in effects. And as much depends on waveform as anything else. So there are some where I've had a patient get their settings tuned in, and within 5 minutes of experiencing for the first time, they're telling me that they're feeling a remarkable difference in pain relief. I have other folks who, it takes a day or two, and then, they're sore from the procedure and other things, and maybe they don't know, and the sedation medicine from the procedure is still wearing off. There can be a lot of other confounding things within that timeline. But what we expect is that, because I only trial patients for 5 to 7 days, I need them to know a result within that time. But often it's very quick, even within an hour or so. There's a paper that we did recently looking at whether same-day chest trialing could be possible and effective. And the idea here would be to do a same-day trial where a person gets a stimulator placed, they turn it on in the recovery unit, they walk around for a while, they can know by the end of that walk whether or not, maybe go to the mall, have lunch, come back, but they know by that time whether or not it's working or not. One of the things that helped in that study, which was Jason Pope was the lead author on, is that was with a closed loop device that was sensing the compound action potentials. And with those ECAPs, you know that you're delivering effective dose that's activating the neural elements within the spinal cord. And so if you can read that objective data back from the cord, and then the patient is experiencing a correlating pain relief, you have more information that you don't need as much time necessarily to trial with. Now, in my setting, because I have patients who get a lot of sedation and stuff, I'm not so sure I want them traveling around the mall an hour after they've come out of the procedure suite and things like that. And so I don't know that will work for every patient, but I think that the more objective information that we have that can help that to let us know that we're providing a technically correct delivery of stimulation and we're seeing an actual physiological response within the spinal cord, then that tells us that we're doing the thing that the device is designed to do. And if a patient doesn't notice within that first day that it's benefit, then you don't stop then. You can just extend it to the regular 5 to 7 day trial and keep working and seeing what else may be the information that comes along with that. So that, I think, is a really important part of it, though, is, what is the timeline? The other piece that we know is that there is, we think, some plasticity in how things change over time. And so somebody may have better benefit and may be more sensitive and require a lower dose of stimulation months after they start using a stimulator than they did when it was first placed. There's probably things that are changing with the cellular receptors that are changing how that is. And so what we also see is that sometimes people's sensitivity to the medications that they take as part of their comprehensive treatment is different as well. And they may be able to change their doses on some of the medications like gabapentin, for example, because the stimulator is changing some of that too. So this is an area that's really very interesting. And of course, Ricardo Vallejo showed a lot of this with the genetic work that he did as the fundamentals for his DTM work. There are changes in various gene element upregulation and downregulation that come with chronic spinal cord stimulation.
Well, and medication, just like spinal cord stimulators and neuromodulators in general, they're just tools, right? Mm-hmm. It's not to discount them, but it is important to recognize that tools like gabapentin have side effects, anything from even memory loss and brain fog, fatigue throughout the day. And so I want to emphasize that from what I've come to understand, the side effects of spinal cord stimulators are generally pretty minimal for patients. Has that been your experience?
I mean, I would say yes. And, I tell patients you can always just turn it off. And hopefully the worse that somebody is with it off is that their old familiar chronic pain is back exactly where it is. Some patients actually find that reassuring. They're like, what happens if I stub my toe? Am I going to notice? Like, yeah, if you're not sure if you're hurting differently or not, turn the stimulator off for a while and do a little inventory of your body. Are you feeling just the old familiar pain? Or are you feeling some other pain as well? And, if you have something new, then, then that's different. But I think that obviously the thing that I worry most about is that it is a surgical implant procedure. So we have to be thinking about the surgical risks that are associated with it at that time. But once the stimulation has been implanted chronically, then from delivering the stimulation itself, it seems certainly very safe in terms of not having longer term side effects.
When you were talking about AI modeling, I'm curious if you think we'll get to a point where we have enough data where we can help predict whether or not patients are going to develop neuropathic pain in order to sort of preemptively explore these neuromodulator pathways.
Yeah, I'm a big fan of prevention. And there's a double edge to this, and it comes from some of the ethics of doing genetic screening for cancer, for example, and things like that. And so just because you have a specific gene expression doesn't necessarily mean that patient will develop Parkinson's or develop breast cancer, but an insurance company might see them as a higher insurance risk. And so the question is, if you know you're at risk as a patient, will that patient make the changes to actually act on that, or will become a fatalistic sentence? And they'll just say, well, I'm going to have back pain no matter what, so I might as well jump out of 15 airplanes now because it's going to come anyway, And so I don't know. And I think different people react differently in that. And so I absolutely think that if there were a specific way that we could identify and prevent, that would be outstanding. And there's people that are looking at, different ways to try to do that. The challenge, of course, is that when you look at degeneration of the spine across all the segments from C1 to the tailbone, you have so many variables of movement. You have so many things that are different within the dynamics of posture and different body shapes and everything else that I'm not sure it's going to be as easy as, oh, there's a genetic marker, now we know. And then if you do see that marker, how are we going to intervene to actually prevent that? And so it's a big question, but I absolutely think it's possible to figure that out. I think the savvy part of it is that sometimes information is just information or it's fear. And sometimes it's better, I think, maybe to be ignorant.
So what I'm hearing is that on the preventative side of things and post-operatively, this active mindset is really important.
I believe that it is. I absolutely think that the most important thing that any person can do is to be proactively engaged in their health and to do all the things possible to minimize what happens with poor health. Yeah, people take that to extremes. And so, then you do it within the realm of what makes sense in that regard, and recognize that even if you do the best job possible, a patient may still have a severe health condition. But, a person who works out and stretches and has good muscle tone and ends up needing a hip replacement is going to have a very different rehabilitation journey than somebody who has deconditioning and is overweight and has several other comorbidities and needs that same hip replacement. So even if there are things that come up health-wise, having the rest of somebody's general fitness in a better optimized situation is going to make them a better candidate for weathering whatever they need.
How do you go about ensuring robust trial design while managing for placebo effect and patient variability?
Yeah, so one of the hardest things to do is to try to create a trial that is really going to withstand a lot of those criticisms. And so one of the things that I've been really grateful to have a learning opportunity with has been work with some of the industry sponsors as they develop these large-scale studies, because they are working hand in hand with the FDA to make sure that what they are proposing in the study is what will meet the bar for FDA approval of the study in the end. So that's the appropriate endpoints, timeline, all of those pieces to ensure that the study is borne out in a way that gets to what is the hopeful endpoint. And for industry, that's often approval of a new device or approval of a new indication, as it was for painful diabetic neuropathy. And so one of the criticisms that I received when presenting this results from the painful diabetic neuropathy to the diabetologist audiences was that it wasn't a placebo-controlled study. We compared using a 10 kilohertz spinal cord stimulator to conventional medical management, which has been very consistent in the neuromodulation space. But diabetologists are not used to device studies. They're used to drug studies. And giving a placebo pill and having a placebo-controlled drug study is a very different thing compared to doing a placebo-controlled device study, in part because trying to deliver a sham therapy, how do you keep a patient blind to the fact that they are receiving a sham? If it doesn't use the battery up in the same way, they know they'll get online and go in a Facebook group and compare notes about how long does your battery take to charge? Mine took 3 hours. Mine took 4 hours. Mine only took an hour to charge. Oh gosh, do I have the placebo? And so unblinding patients has happened in some studies, and it's happened specifically through Facebook groups where people could kind of figure that out. I had that experience working actually in a clinical trial using stem cell therapy, where people could tell based on the length of the surgery whether they thought they got the placebo or the actual stem cell drug for the study. And so you have to be very careful in how to just design a sham or a placebo. The other question is then when you do a study like that, because you're talking about surgical procedure, the patients may very well have a strong placebo effect just because of their anticipation and positive expectations from undergoing surgery for a device. And so how long should that placebo effect last? Well, part of the reason we have a 24-month follow-up in that study is because a placebo effect shouldn't last 24 months. You could make an argument for maybe a month or two. Some people may say even longer, but 6 months, 24 months is a long time for somebody to have a placebo response to something. And so we looked at that and tried to say, okay, well, that seems to be less of a concern. And so, but again, when you're talking about device implants, you don't also necessarily want to subject somebody to the risk of a surgery if they're not actually getting the therapeutic piece of that surgery as well. So you have the ethics concerns of making sure that the protocol is designed the right way for that as well. So there's a lot to take into account. And I think we need to continue thinking about this. And what do you use as a control group? When Saluda did their Evoke study, for example, looking at closed loop, they compared it to a control group using the same device delivering an open loop stimulation. So they had two different groups, and the patient was their own comparison from open loop to closed loop because they were able to cross over between the two at one point during that study. And so that may be a more effective way of looking at things as opposed to looking at a sham control, which might also require a much higher powering of the study, which again, you can do for a blood pressure drug, say. But for a stimulator, which is a more costly study to do, the idea of doing those large numbers just to satisfy that in a design may be really something that's prohibitive.
That's fascinating. And I'm also curious to expand beyond diabetic neuropathy. When we especially look at sensory function, what other sorts of conditions do you imagine this being applicable for? Or perhaps it's already being used for sensory function and I'm just not aware.
Yeah, so I'm really excited for this. And so the area I'm most interested in right now is in non-pain indications for neuromodulation. So there have been case reports all along of things like, for example, using an acute spinal cord stimulation to try to reduce vasospasm after subarachnoid hemorrhage in a patient in the ICU. There's been reports of whether a person's movement disorder, whether it's tremor or Parkinson's, had some improvement after spinal cord stimulation. If somebody's ambulation, restless leg syndrome, for example. So there's a lot of areas. And then, of course, the work that we've seen from Europe looking at spinal cord stimulation for spinal cord injury. And what we can see in terms of improvement there as well, those are all really amazing opportunities for non-pain indications for uses of neuromodulation. There was a session here at NANS earlier today that addressed that. And actually, there was a gastroenterologist talking about using non-invasive vagal nerve stimulation to treat dyspepsia in patients who have functional GI disorders. And so I think there's a lot of places that this can go that is even beyond the sensory component of it. When we talk about where within the nervous system we really can try to couple in and interact.
It's sort of a blend of appreciating all of these NF1 studies and moving beyond this paradigm of looking for pain management as the central
Absolutely.
here. If we fast forward 10, 15 years, do you have any perspectives on where you think this landscape is going to be?
Well, I have an optimistic and a pessimistic sense on this. We were very close to having real restrictions put on spinal cord stimulation about 10 years ago because there was a concern that there were so many in-office stimulator trials done and the trial to perm conversion ratio had dropped precipitously, that people were getting a test trial, but they're not actually going on and having a permanent implant placed. And it became something that insurance companies were monitoring very closely, and the pre-certification requirements went up. And there was a lot that was done to look at whether or not this was an abused medical procedure. We could have lost it. But then we have this amazing data that's showing the kinds of impacts that we can have. We're expanding indications beyond what has been traditionally treated. So there's a lot of opportunity for what we can do. So I'm very optimistic that if we are good stewards of the therapy, we continue to build good, strong evidence for this, and that we don't go into a place where we are showing questionable judgment or being unable to work with the payers who are also scrutinizing this, that we can continue to have growth in terms of the numbers of kinds of patients and conditions that we impact, how we select those patients, how we get that efficacy, and where we see that with smaller devices that potentially have the ability to not even need charging or have amazing amounts of impact and are powered by the technological advances that we're already enjoying and have sort of discussed today. But we've had several publications in the past 6 months of 2024 and in 2023 that were really critical of the spinal cord stimulator outcomes. And some of those are flawed studies. Some of those are studies with bias, but we need to take a real careful look at what the motivations are behind those authorships and what that potentially could do to limit the access for our patients. And so I hope that we don't have that be a continuing trend, but it certainly is possible that while we have an exuberance and optimism for how this can continue to help more people, and we want to help more people, that there may be a desire to sort of squash down and sort of put the lid back on the box and not do this sort of costly procedure for too many patients because it is too expensive for the people that are incurring healthcare costs. And so how we address that as a group of neuromodulating clinicians, how we address that as society, as industry, in order to continue to deliver the right outcomes, innovations in technology, but to do it in a way where we actually can be stewards of healthcare and also manage access to all the patients that need it, is going to be a very fine balance. And so those are the challenges I think we need to watch for in this upcoming decade.
I appreciate so very much the grounded and balanced perspective. And I think I could ask you 24 more questions, but I want to get you to your next meeting. So I will say that I am very grateful for the contributions that you've made to the field, both in your current presidency of Aspen, but then also as a researcher and clinician. And beyond that, is there anything else that you'd like to share before we go today?
Oh, thank you so much for the conversation. I've really enjoyed it. And I hope that this conversation inspires other clinicians to pursue innovation and that together we can continue to grow what we can do to make people better.
Excellent. Thank you for being here.
Thank you.